So this, in 2018, this is when we debuted these top educational content talks, or TEC talks. The 4 TEC topics and speakers are chosen by the Professional Development Committee to address the most important current practice gaps faced by pediatric surgeons. So I'd like to invite Sabina Siddiqui to introduce our first invited TEC Talk speaker.
Thank you. Good afternoon. I'm so honored to introduce Karen Elizabeth Speck for the first TEC Talk of ABSA 2023. The PDC asked Dr. Speck to speak on contrast challenges for acute small bowel obstruction due to her research and her expertise and specialization in this area. In addition to her leadership in this clinical area, Dr. Speck holds a number of leadership positions at her institution and has made a national impact in her areas of clinical research. We are truly honored to have her to share her expertise here today.
Well, thank you, Dr. Siddiqui, for that kind introduction and lovely photograph. I can't tell you guys how ecstatic I am to be here to present what is truly a passion project of mine to you guys today. Contrast challenge algorithms have been described in the adult literature since the 90s, and the number of publications in adults has just increased in volume over the past couple of years. The contrast challenge itself is pretty straightforward. Patients present with an adhesive bowel obstruction. They undergo typical IV fluid resuscitation and gastric decompression. And then they receive 150 to 200 milliliters of gastrografin diluted in water. And then 8 to 10 hours later, they get their first abdominal x-ray. On that first x-ray, if the contrast has made its way through the small intestine, past their bowel obstruction and into the colon, then they've passed their contrast challenge. They're fed and they go home accordingly. However, if after that first x-ray, they still have contrast in their small intestine, they undergo a second abdominal x-ray at 24 hours. On the second x-ray, if the contrast is persistently in the small bowel, they have a persistent small bowel obstruction, and those patients would move forward with surgery having failed that contrast challenge. Now, the benefits of a contrast challenge in adults has been demonstrated for decades now. These are just 2 systematic reviews from 2010. Both of these studies demonstrated, along with many others in the adult patients, both a diagnostic benefit to the use of contrast challenges, whereby passing or failing the contrast challenge helps to determine the likelihood of success of non-operative management. Said another way, predicting the need for surgery. Additionally, there's been a therapeutic benefit demonstrated, with the theory being that this hyperosmolar contrast works its way through the small intestine, drawing the edema from the bowel wall into the intestine, thereby stimulating intestinal motility and decreasing the likelihood of surgery for these patients. Both of these together, you can imagine, decrease the hospital length of stay, both for the patients who avoid surgery, but also the ones who undergo surgery, because it decreases the time it takes for us to make the decision to move forward with surgery. Now, we know that this contrast challenge algorithm has not been quite as readily taken up in the pediatric patient population, and there's likely a number of really good reasons for that, but only until recently we started utilizing them. But we know that children are not just little adults, so maybe there's a reason for it. Maybe the children are a different patient population, or maybe their diagnoses makes them a different patient population. So we sought to understand the practice patterns across the United States for the management of adhesive bowel obstructions in this study. There were 46 FIS participating hospitals, and importantly, we controlled for the patient-specific factors that I alluded to, but also the hospital-specific factors, so that we could really hone in on where is this practice variation across our institutions. I think this data slide really speaks for itself. On the left, you can see the percent of patients undergoing surgery and the 46 participating hospitals on the bottom. And the results really are that there is significant practice variability in the way we manage children in making the decision of who undergoes operative management, ranging from 35% of the time to 75% of the time. So really just a flip of the coin in how we're making these decisions for children to undergo surgery. And what this said to us was really the data that we're utilizing to make the decision about who gets surgery is rather subjective, and therefore begs the question, do we have an objective tool that we can utilize in children that can help us make surgical decisions about these kids with adhesive bowel obstructions? Of course, that leads us into the data around using contrast challenges in children. I'll be the first to tell you that the data are limited. There are only a few studies with small sample size, the first of which was from 2011. 8 children underwent a contrast challenge, and they were compared to 16 matched controls. And then a more recent study, 2019, the Chicago group had implemented a contrast challenge algorithm for children with adhesive bowel obstructions. And they looked at the 26 patients who had bowel obstructions before their implementation of their algorithm and compared it to the 11 children afterwards who received contrast. And we have to acknowledge these are small numbers, but they do both suggest that contrast challenges may have both a diagnostic as well as a therapeutic role, mirroring the data in adult patients. In fact, after this 2019 study that was published, a number of pediatric children's hospitals implemented a contrast challenge to utilize for adhesive bowel obstructions, including our own. But we acknowledge that there are, at this time, still many unanswered questions, particularly around safety of utilizing contrast challenges in children, the efficacy of these algorithms, and which algorithm to use in kids. And importantly, the dose of contrast to use in kids. Is a 70 kilogram adult dosing appropriate for a 1-year-old? Probably not. So this led us to this study that we presented to you guys a couple of years ago here at APSA, trying to tackle that first question of establishing the safety data around utilizing a contrast challenge for children. This is the largest study to date with 82 patients who underwent a contrast challenge, and importantly included even those high-risk patients. 30 to 40% of these patients had pre-existing pulmonary and neurological comorbidities. 5 of our MWPSC sites at the time of the study already had a contrast challenge algorithm in place. And so we did a retrospective review, and we were very excited to see there was a 0% complication rate associated with contrast in these kids. And importantly, the contrast challenge itself provides a high predictive value in discerning which children will be successfully managed non-operatively, which of course informs our clinical decision-making for these children. Now this brings us to our most recent study. We are well underway with the ABC study, Adhesive Bowel Obstructions in Children. The overall goals of this study are to establish the efficacy of this contrast challenge algorithm that we've implemented in these children at our institutions, and we want to discern also the optimal dosing of contrast in kids. This is a 3-year study performed at all 11 MWPSC sites, so obviously multi-institutional, but importantly also multidisciplinary. Even just to create the algorithm, we took into account all of our stakeholders who care for these patients, our colleagues in pediatric surgery, pediatric radiology who actually have to give us the contrast, and then the emergency room providers who have to consult us early. This is a prospective interventional cohort study where implementation of the contrast challenge algorithm is the intervention. And our primary outcome is looking at hospital length of stay, as you can imagine, but also to try to dig deeper into those diagnostic and therapeutic benefits. We're looking at outcomes such as time to surgery, and then of course the overall need for surgery. Now this is our whole algorithm. I don't want you to get lost in the details. We won't go over it in its entirety. There's a QR code for those of you interested, but I'll provide that for you later. I do, however, want to draw your attention to 2 factors in this algorithm, one of which is the contrast medium we've chosen to utilize. Most institutions are utilizing gastrographin diluted in water, similar to the adult data. However, due to some institutional variability and logistical challenges, we also have multiple contrast mediums available. Importantly, this was performed in conjunction with our pharmacists to ensure that all contrast mediums utilized in this study have a very similar osmolarity to maintain that hyperosmolar effect. Additionally, we wanted to be much more discerning in the dosing of contrast in children, which is different than the current literature available. Children under 1 year of age do undergo a weight-based dosing, and then that dosing incrementally increases as children age and get bigger. This study will be complete in October of 2023 with enrollment. At our current pace of enrollment, we expect to have over 250 children in this study. And then these children being followed up for 1 year so that we can discern the longer-term outcomes in these children, particularly recurrence rates. And this data will be available to us in October of next year. Contrast challenges are safe in children, and they do provide a high predictive value to help us discern the success of non-operative management in children with adhesive bowel obstructions. We expect that this ongoing prospective study will help us to establish the efficacy of our contrast challenge algorithm, as well as discern the appropriate dosing of contrast in children with bowel obstructions. Our goal, of course, is to establish best practices for kids. Now, I can tell you, speaking from personal experience, if you present with this abdominal x-ray, you are really excited to see contrast in your rectum at your 24-hour x-ray. And I can tell you that I was grateful that my surgeon had a tool that they could utilize to make objective data in a timely fashion to help with surgical decision-making and maybe even avoid another operation. I'd be happy to answer any questions.
Hi, David Rothstein from Seattle Children's. Sometimes these fail, and do you have any sense yet, just viscerally, no pun intended, like why they fail? I just don't understand it, because we are so excited when it gets there, and still the kids linger and they get an operation sometimes.
No, that's a really good point. The contrast challenge will not be effective in relieving every patient's bowel obstruction, so we know that there will be a certain percentage that will fail. The point in that is it will decrease your time to decision-making to move forward with surgery. We've all had the experience where the can gets kicked down the road and another surgeon switches and someone else is on call, and 2 weeks later, now you're finally making the decision to move forward with surgery. I think that's one of the major benefits of this contrast challenge algorithm. Why they failed? I think they just needed surgery.
Hi, this is Yusuf Gohari, Peds Surgery Fellow at University of Nebraska. Thank you for this lovely presentation. So we started using this algorithm at our institution about 6 months ago, and we had a very difficult time convincing our own pediatrologists to implement this protocol. They started out with 30 mLs of Adhesive. They didn't know what type of contrast, what volume, what concentration. And my very first conversation with one of the radiologists was, oh my God, it worked. It's as if it was almost therapeutic. So I'm looking forward to your results, because right now, as in the peds radiology literature, they're not sure about the volume, the concentration, and so forth.
Absolutely. Thank you for those comments. We, too, struggled with rallying all of our stakeholders. The biggest barrier to even just create this algorithm at our own personal institution was ensuring that our radiologists were on board. I think that safety data study really helped to get our colleagues on board and moving forward with this contrast challenge algorithm. Thank you guys for taking the time to be here with us.